Welcome everyone to another exciting edition of the International Dental Implant Association webinar series. We got a ton of great information for you. This is about 90 minutes is going on. I'm going to tune out and let the speaker take over from here, guys.
Okay. All right. So, hello, good evening, everyone. Good evening, IDIA, and good evening, Miami. I hope all of you guys are safe in your, back home, relaxing. So, I'll be talking about oral plastic surgery for the general practitioner. I'm sure most of the listeners and the viewers are general dentists. So, yeah. Let me start by here. So oral plastic surgery for the general dentist. Okay? So this is a case-based discussion. Yeah, my name is Dr. Carlos Santos. I'm from the Philippines. So here we'll be discussing what is perioplastic surgery. So procedures done in perioplastic surgery. You might be wondering, the title is oral plastic, and what I'm saying now is perioplastic. I'll be explaining that in a while. So we'll be talking about procedures that us general practitioners can do. Unlike referring, instead of referring them to specialists, these are non-technique sensitive procedures that we can do. One of those is the melanin depigmentation. Well, this is technique sensitive CT grafting, but I'll show you some of the cases that we did. Lip repositioning to address gummy smiles, and aesthetic crown lengthening. So again, I'd like to introduce myself. Good evening, everyone. My name is Dr. Carlos Santos. Okay? I have a private practice in Makati City in Philippines. It's the Central Business District. Well, I'm not an oral surgeon. I don't want to consider myself one. I'm a general practitioner, well, interested in surgery. I said general practitioner because I still do, onlays, inlays, dentures, fillings, root canals, the normal stuff. Okay, we have a small school for dentists. It's called Center for Innovative Dental Studies, or SIDS. It's it's like a study group, an informal study group where dentists, gain confidence and learn surgery, oral surgery. So I used to teach in the undergrad in Punciano College of Dentistry, and I was the president of Makati Dental chapter of the Philippine Dental Association, an active member of the Philippine Society of Periodontology, and an active member of the Philippine College of Oral Implantologists. Okay, so, well, a little bit about the workshop, because what I'm going to show you, what I'm going to discuss are procedures done by our colleagues, our participants and students in the oral surgery workshop. Okay? So these are okay? So that's us, just having fun and learning. So this is our suturing clinic. All right, so just to show you. Okay, so here we not only learn the participants not only learn, but also both participants and patient, we give back to the community. We get patients, the less fortunate ones. We do it for free, the procedures we share, and of course we get to learn. So these are some of the procedures that they've done. Okay? So this is one of the lip repositioning there. Okay, so a few of the surgical procedures we did for free. All right, here. So we actually, in the workshop, we give back when we change lives. So I'd like just to quote this by Robert Ingersoll: "We rise by lifting others." Okay? Anyway, so guys, Before I start, I just want to show you this. No, so the new normal. No, I hope everyone is who went back to their practices. Follow the COVID-19 infection control protocol. I just want to show you this. It's a prototype mask that my friend designed. This was featured in CNN actually. Okay, note that the mask is fully like smack in your face, but it's not difficult to breathe because there's a regulator here. If you can see, just want to show you this quick before we start. So here you have a USB port here. That this has a fan. Also, you can connect oxygen tubes here, so it's really not hard to breathe. So I just wanted to show you guys. All right, and okay, now we start. Okay, so oral plastic surgery for the general dentist. So I consider myself like what I told you. I'm a general dentist because I still do the normal dentures, inlays, onlays. But I'm really very very interested in oral surgery. Okay, remember in doing oral surgery, your instruments must be correct. I mean, precise. You have to have the correct instrumentation. But I won't go deep into that because that's not the topic. But yeah, your mucoperiosteal elevators, your blade, your curettes, okay, your tissue forceps. You have to have those. You need to do this. No? I'll be discussing cases that, like what I said, instead of referring them to your specialist, of course, difficult cases we refer because it's not in the realm of our practice. But I'm going to present cases that are relatively not technique sensitive that I hope that you incorporate in your practice after this discussion. Okay. Rest assured, all these patients that I'm going to present, I got their permission in showcasing their cases, and one of them, this lady over here, is actually a dentist also. So, all right. Um, so let's just name them patient 1, 2, and 3, and 4. That's the fourth one. I had to paste the picture because we didn't get the pre-op picture. But anyway, okay, let's start. So remember, guys, in oral plastic surgery, okay, it's like plastic surgery. The goal of any treatment is to enhance natural beauty in the safest possible manner, which is multidisciplinary. So we need other disciplines, in order to achieve that aesthetic goal that we want, okay, normally. Okay, so here you can see the patients that went to our workshop and got that smile that they wanted. Okay? So this is very common. I'm sure every one of you encounters this. Very common, most in our female patients. So cosmetic therapy, a dental demand. This is where we go in. People go to their cosmetic surgeons, to have their nose lifts, Botox. So I think as dentists, we play a crucial role in achieving beauty, because like you cannot achieve that beauty that you're looking for if your teeth is crooked, or you have a bad smile. So here, as you can see, a very beautiful face, but if you look at the left side, something's missing, and that's where we play in. That's what our profession plays in. Okay, so periodontal plastic surgery. Okay, these are surgical procedures performed to correct or eliminate, well, anatomic, developmental, traumatic, or disease-induced effects of the gingiva, alveolar mucosa, and bone. Remember, when you talk about the periodontium, you have to consider three aspects: bone, tooth, and gingiva. Without one of those, it's not the periodontium. Okay? So take a look at this picture, because these landmarks are the only landmarks, that we will be needing in the procedures that I will discuss and teach you today. Okay, so we have the mucogingival junction here. We have this the attached or the thick part of the gingiva. Okay, and we have the unattached. So just three parts: mucogingival junction, the unattached, and the attached. Okay. Okay. So P.D. Miller, he was the one who coined this perioplastic surgery. It came from this guy, the term perioplastic surgery. So well, it addresses the color defects of the gingiva, like also the physical defects like the frenum, excessive frenum, abnormal gingival margin, and the abnormal gingival display. Now, I called it oral plastic surgery because, you know, okay, like what I said, it addresses these problems, and these are a few of the treatments or cure that could address all of these problems. Now, when you say, well, if you include hard tissue augmentation or hard tissue treatment, like bone reduction, and emergence profile consideration, I think that makes it oral plastic surgery. And I wanted to include that in this lecture. Okay, so let's discuss about perioplastic problems. So the problems that we encounter, in our everyday practice. Again, I'm encouraging everyone to at least try to incorporate this in your practice, because I'm telling you, it's really not difficult. Okay, so color. So we're familiar with the amalgam tattoo. We see this, but in the era of nanotechnology, of composites, we seldom see this. But yeah, there still are. And tattoos on the aesthetic zone, they're really, something to address to. Okay, next is your melanin hyperpigmentation. Okay, so you can see this in blacks, actually Asians, you have this, and also people with gummy smiles. It's common. Okay, next is your abnormal gingival margin. Okay, these are the problems. So hyperplasia of the gingiva. We seldom see this. We actually refer this to the specialist, but it's actually not that hard to manage. Okay, so I'll show you how. And this is an actual case. Sorry, receding gums. Receding gums. Okay. So yeah, this is one. I'm not an orthodontist, so but this is one of the treatments that they do to what you call that, to pull the teeth back, to intrude the teeth. Another problem is abnormal gingival display. Now, actually, this is one of the main topics of this lecture: addressing abnormal gingival display. Okay, or your gummy smile. Okay, hard tissue issues and issue with emergence profile. So you can see bony exostosis, and for those of you who does implants, of course, we'll talk about emergence profile. Okay, guys, before doing all of this, we have to determine the types of smile. There are three types of smile. One is your commissured smile or your Mona Lisa smile. It's just like walking, and you see a person that you might know or says hi. This is the smile that we do. Next is your social smile or your Cupid smile. This is the most common smile that we do. When we do our selfies, when we post our pictures on Instagram and Facebook, this is the smile that we do. It's a practiced smile. So people with gingival show issues, they practice this type of smile. Next is the spontaneous smile. This is or complex smile. So this smile is the smile that you do when someone's really funny, so you laugh out loud, and this is the smile that you do. It's a spontaneous smile. It's like occlusion on maximum, but this is smiling on maximum smile. Okay. So let's discuss about this fast. So factors. This is very basic. Factors affecting the gingival color. Of course, we know that the normal color is coral pink. Okay. So the stippling, we must see that for us to determine the that it's normal and healthy. Okay, so the factors that determine the color are blood vessels, very important. That's why I always tell our students that bleeding, when there's bleeding, there's healing. Our mouth being very vascular, if there's an injury that occurs, trauma or any wound that occurs in the mouth, because of its vascularity, it will heal. It will, definitely heal because of the bleeding. So blood vessels, so epithelial thickness. So this is the biotype, degree of keratinization, and pigments within the gingival epithelium. These are the factors for the color. So they're melanin, keratin, and all those. But this is not interesting. Let's go to the treatment. Okay. But of course, Dumet et al. 1964, they made this oral pigmentation index. So remember, we're discussing about gingival color. Okay, how to address it. So basically, this type of surgery is the surgery prior to aesthetic dentistry. So for those of you who does veneers, bridge work. I mean, whose career is focused on that. This is the surgery before that. So of course, in a good smile, we have to address the pink, the white, okay, and of course the lips. Those are the factors that makes a good smile. The lips, the pink factor, the gum, which is the gum, and the white, which is our teeth. Okay. So 0, 1, 2, 3. Okay. No clinical, mild, moderate, and heavy. Okay, let's start. So we call the procedure. This is one of the most least technique sensitive of all the procedures that I want you to incorporate in your practice. It's called gingival depigmentation. So clinical melanin pigmentation is completely benign and does not present a medical problem. So it's dictated by race. Okay? Sometimes it's pathological, but very seldom. Okay? So demand for cosmetic therapy is made especially by fair-skinned people with moderate or severe gingival pigmentation, mostly patients with gummy smiles. Okay? So this is the depigmentation is the periodontal plastic surgical procedure whereby the gingival hyperpigmentation is removed or reduced by various techniques. Okay, so we'll be discussing 3 techniques that us general practitioners, you the GP, can do in your practices. Okay, guys. Scalpel used for partial thickness. Okay, so just your plain number 15 blade. So what you do, given the okay, so you put anesthesia here in the vestibule. Remember, the secret in a profound anesthetic technique that for you to get hemostasis is actually you do it in slow motion. It's like brushing your teeth. You sing 2 nursery rhymes. So that's the duration. It's very slowly inject in the vestibule. So you will finish around 4.5 carpules to three, around 3 to 4 carpules of lidocaine, xylocaine here in the vestibule area. So do it slowly. Also for it to for the epinephrine to engage. Okay, do it slowly. Okay, and then a little local anesthesia here in the pigmented area. Okay, so what you do, it's like peeling potatoes. It's like peeling a kiwi fruit. You don't scrape it. You just slide. You just fillet it. So the pigments actually are located in the stratums, the strata, the layers. Okay, so you just have to get your gauze, okay, moist gauze, and then while filleting, while peeling it, you just dab the area, and then check if there's pigment. So the pigments are gonna appear brown or black or gray. Make sure there's no pigment. You might be asking, Doc, what if we hit the bone? What if we were in the periosteum? Okay, remember, we're just doing a split thickness. We're not elevating the flap. So the periosteum is still there. Okay, so, all right. So this is the layer that we took out. So you see, here he got it in one go, in one filleting action. So remember, you will use around, three to four, 15 blades for this. So then allowing the denuded connective tissue to heal by secondary intention. So this is the final result. You might ask later, should we put a periodontal dressing or perio pack? Personally, I don't, but the literature says you must. But because my only reason is it's hard to clean. When eating, debris will go in, and it's better for you to be able to clean it. So what we do in our workshop, in our practice, is we construct a tray, to protect it, so that it's also to easily remove it and flush the area. Okay, so there. So here, one of the cases that was done in the workshop. So you see the motion is slicing. So if you can see here, different. So from dark to, so this is around 2 weeks after. Okay? 2 weeks after. Okay, will it come back? Will the pigmentation come back? Actually, if you don't address, if you leave the pigments there, if you leave like a speck of pigment, in our experience, it will come back. But the patients that we did, there's no relapse yet. It's been like years, 2 years, 1 year to 2 years, nothing recurred. So you just have to address every pigment that is noticeable. Okay, this is another technique that you can use. So using your diamond burr. Okay, so deepithelialization involves removing the epithelium and the pigmented areas with a high-speed handpiece. But you have to have control. It's like using a colored pencil that you're coloring lightly. So that's the force that you because remember, that's a diamond burr. It can go through the. I mean, it really can do damage if not handled properly. So yeah, it is recommended to use the largest diamond burr suitable. So actually, we use the pear shape, the flame shape burr, okay, and of course with irrigation, copious saline irrigation. Okay, so this is the pigment. See, by using the burr, again secondary intention. So this is the final result. So let me show you how the strokes are. How to do this. Sorry. So I hope the video is clear. So just a brushing motion and irrigation. So yeah, you'll see bleeding like that, but that's okay. Remember, guys, when there's bleeding, there's healing. Okay, so don't take that out of the when doing surgery. Don't take the bleeding factor out. Okay, so this is the before picture. See, the patient was concerned of this actually very, very light stain, and so you see the diamond burr was used here. Let me get my. Okay. So guys, this is betadine. Sorry, iodine, povidone iodine. Okay. So here's the finished product. So she's happy with it actually. And there. Okay, next, for those who have lasers, who in their practice have lasers, actually it's also an option, So, but actually we were joking about this. I don't know how much the blade costs there, but it's around maybe here it's around like less than $1. The number 15 blade. So instead of we were joking that instead of buying like a thousands worth of laser, we'll just buy a blade less than $1. But anyway, for those of you who practices laser dentistry, this is also a good medium to use. So, and it's actually faster, of course. So you see the final result. So again, these are the three procedures that you can actually do. You can add to your services prior to placing your veneers. It will, of course, definitely add to the aesthetic value of the patient. Okay. Okay, so all the remnants of melanin pigmented areas of the iris should be completely removed. Remember. Okay, okay, so okay, let's go to the next. So abnormal gingival margin. Okay, again, let's discuss this. So this is the attached gingiva, our frenum. Remember the frenum. Okay, its function it's to hold the lips close to your mouth, close to the vestibule area, and also it serves as our midline. That's the I'm mentioning this because later you'll see why I mentioned this. Okay? So this is the unattached, the attached. Okay, so okay, this is very important, guys. The biologic width. Well, I see some then some students or participants like they don't consider the importance of our biologic width. So remember to summarize what the biologic width is. This is the area that you can't touch. This is the area that's a no-no. To if you put your crowns, your veneers, if you place it in this area, okay, failure is it's like a time bomb. Failure is bound to happen. Your biologic width, inflammation will start. Okay, bone recession, gum recession because of the inflammation. So it's very important. Why, we will discuss why. Okay, so now it's very important to know where it came from. What caused it? So like for example, this one. Okay, you can see that despite oral prophylaxis, there's still hyperplasia. Suspect something else. Usually these are drug induced. Okay, or sometimes hormones. Hormones can cause this. Toxins, but usually they're drug induced. So of course, to address this, you have to address what caused it, which is the drugs that, or maybe the medicines that the patient is taking. Okay, so okay, we love doing this actually. I'm sure most of us, or if not all, have tried doing a gingivectomy, or where you sculpt the gums. People who has the electrocautery, you just sculpt the gum, and wow, it shows the tooth that is hiding, the teeth that are hidden inside the gums. But remember, patients are genetically by birth, their gums are designed like that. So notice that when you do that, a couple of months after, the gingiva will grow back. So that's why there are modifications that we do to avoid those. Okay. So again, gingivectomy is indicated for, of course, suprabony pockets, gingival enlargement, and periodontal abscesses to cure periodontal disease, to address periodontal disease. But okay, of course, gingival recession, one of the components, one of the problems that we encounter in under the gingival margin problem. So PD Miller classification, again, this is well, this is more of a specialist. I mean, I'm not encouraging you to really go into this, but yeah, this procedure, the connective tissue graft, is, well, of all the procedures presented today, this is one of the, well, like what I said, I'm not encouraging you because this is a specialist's job, no? But it takes practice only. I mean, like what I said, I'm a general practitioner, but we do this, no? And I'm going to show you the work that general practitioners did uh, in our workshop. Okay, sorry. So as you can see, the canine has receded gums, also the premolar. But yeah, they wanted to try it, and we did this canine. So we take out the composite, Okay, composite, it releases methacrylic acid, most especially those old composites that are micro hybrids. Those, but now it's nano. I think it's less. No? I'm not a dental material expert, but yeah, but when you cure it, it's not fully cured, so it releases metacrylic acid that the gums doesn't, it avoids it. That's why, combined with your toothbrushing, the trauma in the gingiva, one factor that plays a role also is the release of that metacrylic acid. So we remove that, we expose only the dentine, and we shape it. I used a piezo instrument here. So okay, sorry to show. Sorry for the blurred picture. So this is the first day. We got this from the patient's palate. As you can see, it's bulky. It looks, wow. It looks that it has a periodontal disease. Okay. Okay. So again, this was done by general dentists. Okay. First timers. Okay. This is after 1 week. You see that it's starting to be one with the surrounding tissue. Okay, this is after 2 weeks. Okay, so it became one. It's there's a little redness. Okay, so see now it became thick, very thick. So we want that. It's better thicker than thinner. So yeah, the patient is happy, and amazingly, the dentist, the general dentist who did this were amazed. Actually, it's their first time. So, but like what I said, I'm not encouraging you to do this because this is technique sensitive, really, most especially harvesting the connective tissue. I'm just, for the purpose of showing. Okay, this is one of the procedures that we've done in our practice around, well, 8 years ago. So we got it from the palate. So this is old school. There's a lot of techniques now, but this is really old school technique. So it's underneath a coronally positioned flap there, and then after 10 days. So imagine, guys, the thickness that it achieved. So definitely for those of you who does implant, the importance of the connective tissue in repairing those in those neck areas. So it really creates that thick keratinized attached gingiva that you want. But anyway, like what I said, you refer this to the specialist if you're not used to it. You have to practice. In everything we do, the only secret, no one is born with the good hands. It's about repetition, repeating it over and over again. That's how you get better. Okay, abnormal gingival display. Now we're talking. This is actually the one of the main topics of this lecture. So it's also called excessive gingival display. It refers to individual suffering from an abnormal gingival display. So usually this is 3 millimeters and up. Okay, mostly female has this. Okay, this is my daughter. She has a gummy smile also. So not all gummy smiles are the same. Okay, so we have to consider, again, very important, the etiology, or what type of gummy smile it is, so to speak. We're talking about gummy smile. So first is the gummy smile that is indicated for, that is present in facial proportion. Next is gummy smile in patients with short lip. Okay. Next is gummy smile with hypermobile lip. And last is tooth proportion. So I'll explain each. Okay. So facial proportions. These are patients with vertical maxillary excess. Here we go. So patient number 2 a while ago. So these patients a while ago, if you saw them, these are all patients that went to our workshop that wanted treatment because of, well, they're not happy, of course, with their smile. Their confidence level is down, So, of course, we treated them. Okay, and let me show you how we did it. So, vertical maxillary excess. If you divide the face in 3, so it's supposed to be equal. People with vertical maxillary excess has an excess amount of face if you divide it by 3. Okay, so possible treatments: orthodontic surgery, well, lip repositioning. So orthodontic surgery, this is too morbid. I mean, post-operatively speaking, Patient will, the pain factor is great in orthodontic surgery, and it's too invasive. Well, lip repositioning won't fix this like alone. It's too maxillary. It's too the excess is too wide. And remember, we're talking about epithelium, so it's like making a buckle with a buckle flap. If you stretch it a couple of weeks after the flap, you'll get your vestibule again. So epithelium, it's elastic. So lip repositioning itself won't fix this. So aesthetic crown lengthening, of course, it will help, but will not fix. And lastly, combination. That's what we're, eyeing for. So next. So when we talk about short lip, so this is the decreased height of the upper lip. Usually these are patients with the arched upper lip. So 4 millimeters gingival display when smiling. So common in female. So Botox, definitely you're familiar with this. There in the States, you use this in dentistry. So to address gummy smiles, sometimes TMDs, sorry. Okay. Next treatment is lip repositioning. Of course, combination. Okay. All right. Next is your hypermobile lip. Okay. So lip movement upon smiling is 6 to 8 millimeters. So if you have this is the normal. If you have a hypermobile lip, it moves 2 times the normal. So when the patient smiles, 6 to 8, it rises. It moves 6 to 8 millimeters times 2. So the width and the height. Okay. So again, lip repositioning, aesthetic crown lengthening will solve this. Okay, another hypermobile lip. Okay. Next is tooth proportion or altered passive eruption. Okay. Well, usually aesthetic crown lengthening will solve this, but sometimes you need lip repositioning. Or you can use your choose perio gauge. Later, I'll show it to you how to use that. So that's altered passive eruption. Okay, so again, the treatment of choice is lip repositioning. Okay? Like what I said, gummy smile patients come to our practice we see this often. And sometimes, we don't give possible treatments that can address this. Like what I said, this procedure is not technique sensitive at all. I'm sure if you know how to use a scalpel and you know how to do an interrupted suture, I encourage you to incorporate this procedure in your practice. Okay, so take note of this. No? Lip repositioning is a surgical way to correct gummy smile by limiting the retraction of the elevator smile. Okay, take note. We have to limit the action of the elevator smile muscles. So these are the zygomaticus minor, okay, levator anguli or oris, orbicularis oris, okay, and the levator labii superioris, and yet preserve the labial frenum. Let's start. All right, so sorry. Okay, so this is your orbicularis oris. Okay, this is your zygomaticus major. This is the minor. Okay, these are the only muscles that we will be involving in our procedure. I'll show you how. Okay, okay, so this is patient number 1. Look. Okay, so she has vertical maxillary excess. So this patient actually is a dentist and felt really bad about her smile. So she was a participant and volunteered herself to be operated on. Okay, so this is her doing the second type of smile. No? Okay. So this is a practiced smile. No? It's not the smile at maximum. So let's see. Against patient number 2, if you can see that excess again, that the vertical maxillary excess. So here it is. Closer look. And patient number 3. This is altered passive eruption. Okay. So these are the facts. A lot of articles online, about 104 publications, but no conclusive literature. There's really no there's no study done. No, there's no journal proving that long-term effect of the procedure. No? Okay, most are just techniques done and its description, and all are short-term studies. Okay, so there was a randomized clinical trial done 2016 by Lumiere et al. So they did it, they studied with myotomy. Remember, we have to address those muscles that I mentioned. So one with myotomy, one without myotomy. Of course, like what I said, you'll see how it's done. We're involving epithelium, and epithelium is elastic. It's like doing a flap. For example, doing a burger's flap, or the flap that you will close this. There's a oral-anal communication, so you get a flap from your buccal side, pull it, to the palate, and then suture it. A couple of weeks, months after, that area is vestibule once again. So they tried doing it with myotomy, and yes, it's more effective. It lasts longer because the problem with lip repositioning. Okay, let me go back. People with severe class 2, those retrognatic patient, those whose jaws are really retrognatically positioned. That's one of the contraindications, because the moment the patient smiles, it really stretches it, and it's times 2 of our normal smile because of the position of her chin. But yeah, there's a way actually to address the relapse of this. That's why there's no study. I think because once you do this, it really relapses a couple of months after. But I'll show you. I'll show you this procedure that stops that relapse. So this is so again, before doing any surgical procedure, well, what we do, we pray. So whatever religion you have, it's hard that you pray during the procedure when you're stressed than praying before the procedure. So ask for guidance, and then okay. So of course we measure. So this measures around 7 millimeters. So also a combination will be done here. You see, there's a lot of tooth structure hidden here. Okay? But anyway, so let's do lip repositioning. So after measuring, okay, again, this is the diagram that I showed you a while ago. So attached, unattached. Okay, we will be incising here at the mucogingival junction. So this is the junction. This is the area between the unattached and the attached. This is the area that where the attached and unattached meets. Okay, so as you can see, I followed the area where the tissue meets, the attached and unattached. Don't make a straight line like this. No? It's gonna, well, this is more long lasting, because you will be suturing the top part and the bottom part together. So this is more long lasting because yeah, you're on the edge of the attached gingiva. So again, make another incision. So here we are preserving the frenum. Again, it's because it's a landmark, and so for some reason, for example, your patient has a crooked nose, you don't have any midline, at least you have your frenum. Okay, so to get the measurement of the top part, remember, just stick on the 10 to 12 millimeters from this line. So 10 to 12. So with your perio probe, just measure 10 to 12. Okay. So the other way to get this is this one times 2. Okay. The amount of gingival show times 2. But if to make it easier, just stick to the 10 to 12 millimeters. Okay, from here to here. So this is stretched. Okay, you stretch using a cheek retractor, or just using your hands. You stretch the vestibule, the lips, so that you can get the. So given that you're stretching it, you measure 10 to 12 from the mucogingival junction. Okay, okay, and this extends until the mesial of the first molar. Okay, so mesial of the first molar here on the right side, mesial of the first molar here on the left side. Okay, again, the height of this is 10 to 12 millimeters. So it's creating the line. Okay. So after which, so you get your you'll be using around 4 to 5 blades, maybe three to four. If you're being conservative. Remember, the moment the blade touches bone, it becomes dull immediately. So here you cut 90 degrees. This is the bony part. Okay, here, just cut until the epithelium. Don't reach the muscle part. Okay? So the epithelium is around, if you're using your 15 blade, around 1/4 or close to half of that, the depth of incising. Okay, so let me show you. So there. So you're doing a split thickness. Okay. So this was done in our workshop. So yeah, this is the epithelium that we got after doing a split thickness. So let me show you. I hope this is clear. So yeah, you see, it's like the you don't reach the muscle part, just the epithelium part. On the top part of the incision, the second incision line here on the top, you just the depth of the cut of the incision is around 1/4 or around 5 millimeters of the blade. See there. So you avoid the frenum. So this is your finished product. If you can see, as you can see, the muscle fibers, okay, the strands of muscles, you'll see, you really can't see in the picture, but clinically, you'll see it ranges, the strands are in different directions. No? So this is the most important, actually, part of this to make your procedure successful. I think in the past, in our past workshops, the first, maybe second and third, when we did this procedure, actually, sad to say, it relapsed. It really relapsed. I mean, if there was improvement, it was around 20%, and that's very unacceptable. No? So what we do, like what I said in the when we described the meaning of lip repositioning, is we limit the muscles, the muscle function of the muscle. So this is your orbicularis oris, right? So okay, what we do is we suture it using an absorbable suture. Okay, an absorbable suture. Okay? So these are, if you can see here, these are minor salivary glands. So take that out. You might get small mucocils. So you just cut it out using your iris scissors. But anyway, you see the muscle strands. So what you do, you bundle it. What we do is we bundle it. It's like doing a ponytail, or a curtain. You bundle it. So with that, you're literally injuring it. You're literally what you're doing is you're injuring it, and you're limiting its capability, its muscle capability, its action. So you have actually the picture I showed you a while ago, where you have your orbicularis oris, which is this one, and then your zygomaticus major and minor. So you don't necessarily need to get everything. You just need like a portion of it and bundle it. Okay, so let me show you. Okay, so for a while. I hope you can see it clearly, but yeah. So these are the vertices. So remember the direction of the needle of the insertion as well, imaginarily towards the eye. So you follow the contour of the maxilla. Sorry for the amateurly taken video. So there you go. So see, as you can see, the muscle fibers, it's we just bundle it. Really, it's like curtains being tied to get bundling a curtain or doing a ponytail. We limit the function of the muscle. Okay, sorry for the drawing line. Um, it's not as I wanted it to look like. But anyway, as you can see, okay, so this yellow circle, remember this is under the frenum, under. So this is your orbicularis oris muscle. Here is your zygomaticus major and minor. So definitely you will see those strands. No? You just have to bundle those. Okay, you just have to like what I said. You don't necessarily have to get you. That's impossible to get everything. Just a portion of it and bundle it. So you limit. It's like, for example, four men standing beside each other, okay, carrying a pole or a plank. Remember, okay, if those four men that are standing beside each other carry a plank together, they will be able to carry it with ease. But try tying them together, those four. Try tying them together. Okay? So ask them to carry that same plank. They won't be able to lift that plank the way that they did without them being tied. So so you can picture what we're doing here. Okay. So after that, we bring it down and then we just use our interrupted sutures. Okay. So closely, remember, it has to be well around 2 millimeters at the least. 1.5 to 2 millimeters far from each other until you close. It's mesial of the first molar to mesial of the first molar. Okay? So there, another image of that. Another image. Okay, so the side effects of this. Okay, so you can see before and after. Okay, like what I said, if you don't do this, this will recur. If you don't do the muscle bundling, this will recur definitely. If not recur, uh, I mean it will reduce the show, but the patient will not be happy. You have to do the muscle thing. So that's 6 months post op. Okay, so one of the side effects is the scarring. You see this, the scarring, but it's not shown. Don't worry. When the patient smile, you don't see that. Okay, again, this is patient number 1. This is her teeth before. So this is the same type of smile. This is well, almost the same type. But yeah, what we did with patient number 1 is a combination of lip repositioning and aesthetic crown lengthening. We'll discuss aesthetic crown lengthening after this. Okay. Patient number 2. So again, combination. So I'd like to commend Dr. Gemma for doing this, one of the students. Okay. So actually, one of the side effects that that women, the girls, that they really like about this procedure is the lips thicken. It really makes it thick. If you notice, okay, it thickens their upper lip. It's like having a So there. So look at the lips, huh? And actually, it makes your lips more red. No, just kidding. The the patient placed the really red lipstick. So okay, patient number 3, as you can see, this is her. Okay, this is done by Dr. Judith. Okay, so one of the students also. So this is 5 months after. Okay, so that's her 5 months after. So see the thickening of the upper lip. Okay. Okay, now we go to crown lengthening. So there are 2 types, aesthetic and functional. Okay, why do we do crown lengthening? So it's for aesthetic reasons, to correct either gummy smile or gingival overgrowth. So for restorative reasons, of course, increasing the crown ratio, retention, exposed subgingival caries and fractures, and raising the restorative margins by increasing the amount of sound tooth structure. Okay. Again, biologic width should be preserved. So Very important. Okay, so this is the choose aesthetic proportion gauge. I'm definitely sure most of you, if not all, has this. So, like for example, musicians, they when they hear a song, they play it by ear. You know, they copy it and transfer it in their hands or their voice by ear. Okay, as dentists, sometimes we work using our eyes. No, so we eye it. We use our well dentist instinct that this is beautiful, this size is beautiful. So, but you with using your choose proportion gauge, actually you're precise. You know? You're not guessing. So it's very easy to use. Okay, for those who haven't tried using this, you just where the red line it hits. So the top red line should hit also. So that's the correct way to use this. If it hits here, so the top portion should be here. So, uh, so this is the correct ratio, 75 to 80%, okay, of tooth length and width. So the T-bar proportion gauge. Okay, so let me show you the perio gauge. So this is for aesthetic crown lengthening. Again, you just place it right on top of the tooth. So where the red line lies, so the next red line, that's your okay, that's your point where to cut. So it's like festooning. You know, remember in our undergrad years where we festoon wax, right? So it's just like festooning okay, when you're contouring the gingiva. But there's but this procedure has some modifications from our usual gum contouring, or sometimes we just do gingivectomy without this particular procedure. So this is very important. Okay, to show you. Okay, here a picture, the first picture, you see uneven. So we know that the zenith or the length of the central incisor should be the same with the height should be the same with the canines, right? So we have to fix this. This is not even. Okay, our blade, remember this is very important, okay, should be angled 45 degrees. Okay, this is 90 degrees. This is 45 degrees. Okay, it should be angled. Okay, so first we cut the top part. So we cut the top part. Okay, and then we, of course, this is measuring the biologic width. So we reduce. So we cut around 2 millimeters of tissue, 45 degrees, using a 15 blade. Okay, and then of course we reduce 2 to 3 millimeters of bone to achieve that biologic width that we want. All right, so we do a coronally repositioned flap. Notice that the flap design, this is very important, guys. Look at this. The papilla is still here. So what they did is a papilla preservation flap. Okay, it's just like doing an envelope flap, the normal envelope flap, but not including this one. Because remember, when doing oral surgery, when doing flaps, expect a 1.5 to 2, 1 to 1.5 millimeters of recession when you do flap surgery. So this is the aesthetic zone, so we don't want black triangles. That's why we're doing a papilla preservation flap. So this is the finished picture. So again, that's the only difference from the normal gingival contouring that we're used to, is reduction of cortical bone. Okay? We reduce the cortical bone. Okay? So remember, where the bone goes, the tissue will follow. So the relapse of it being gummy again, being covering the tooth again, is actually 0. Okay, the chances of it for the gums to grow back again is 0. Okay, so this patient, if you can see the, okay, so this is her pre-op picture. You see the, it's not as gummy as the previous, but yeah, you can see the patient is not happy. Okay? Again, there's a lot of tooth structure underneath. So what we did, so this is the post-op after the operation. Okay? We removed the braces. So after 6 months, okay, this is how we did it. So notice that there the papilla is still there, okay? And we did an envelope flap. Okay? So sorry. Before doing this, you contour the tooth in the length that you want, using your perio gauge if you want, or just by using your perio probe. Then measure around 2 to 3, then cut here in this area, 45 degrees. Okay. After that, you make a you do a papilla preservation flap. Don't include this one. Remember, you always respect the papilla. This is the hardest, to augment or to place. Regenerating papilla is the hardest. Okay. Again, do an envelope flap, a full thickness mucoperiosteal flap. Okay, and then, yeah, you can now address your cortical bone. So we just use this pear-shaped diamond burr to contour. It's like what I said. It's like festooning. Okay? So festoon. No, again, notice that the papilla is still there. So this is post-operatively. We were pulling the lips here. So to show you, just to show. Okay. So when this heals, so this is her. So right there and then, the patient is happy seeing her, her hidden gems. Okay, this is 6 months after and 1 year after. So compared to before, patient is 1 year after. So remember, where the bone goes, the tissue will always follow. So another patient. Okay, so, okay, very important before I end this, okay, how long does it take before proceeding to the final restoration? Okay, this is very important. So not before 4 to 6 weeks. So if you're going to do veneers or crowns or whatever, not before 4 to 6 weeks following gingivectomy or gingivoplasty. In the aesthetic zone, before 12 weeks after surgery is required to be sure. Okay? No further gingival recession will occur. 8 to 12 weeks are needed if bone is exposed after flap elevation. Okay? If bone was removed, not before 6 months, okay, for soft tissue stabilization. Okay? The bonding of epithelium with connective tissue total recovers in just 4 weeks. So you will get a weak epithelium. This is if you've encountered like infected gums, no. So that's the quality of it. If you do it before 4 weeks, okay? The gingiva is weak and easy to be injured. So this I don't encourage you, but again. To do this, but again, the ones who did this was general practitioners that went to our workshop. So as you can see, there's a collapse in the ridge over here. So well, we did a Ramos graft, a bone block graft, transfer it to her. Well, she didn't want implant to start with, so she's comfortable with dentures, but she didn't like that drooping effect that her tooth. Her what do you call this, alveolus has. No? So again, I'm almost done. So there's the finished product. So see, compare it. Okay, there. Actually, this is, you just need. That's why we advocate in our workshop. It's more of a experience based. People learn because dentists learn because they do it hands-on. It's not lectured, and you don't do, because we're all doctor. Well, that's what we do here. We're of course supervised by our clinical instructors and by me. We don't do lectures and pig's jaw. So I mean, we do that at first, the pig's jaw, just to simulate, and then we do it on live patients for them to really learn the skill. So another, before I end this, just to show you. You see this, the torus mandibularis and bony exostosis. So that's why we coined it oral plastic surgery. This is one of the services that we as general practitioners can provide our patients. So it's a very simple technique. You just make a flap, okay, underneath. Okay, make sure you until the end. Then yeah, just section it, and then it's like doing an odontectomy. Use your surgical burr, and then yeah, here. So look, before and after. So before and after. See, so okay, the patient. Okay, you might be wondering why I did this, why we did this, and there's it's a pre-prosthetic procedure. The patient was having a hard time speaking. That's why we consider doing this, but never do this those small ones without it. Remember, it's a pre-prosthetic surgical procedure. If the dentition is complete, it's going to be it's useless if you take out small exostosis. But the patient was having a hard time like speaking, because of this. That's why we removed it. And again, the bony exostosis, just using your surgical burr, make a flap, and then reduce it. So yeah, all of these are patients' request, but this is harmless to start with. This is not pathological. So, but the request of the patient, because of aesthetic reasons, so we removed it just using your surgical burr. Okay, mistakes are painful when they happen, but years later, a collection of mistakes is what is called experience, which leads to success. So remember, not for anything else, the greatest teacher that can teach us actually is experience. We have of course to do it for us to try it and to experience it. So with that, so I just saw this and it really, I was wondering how they did this, but with that, thank you for listening, guys. If you have questions, just okay, bring them all in. So thank you guys for listening. Stay safe, everyone. And again, thank you, Doc, for inviting me, Dr. Aaron. Thank you, International Dental Implant Association. Thank you, guys. Okay.
Doc, that was an amazing presentation.
Thank you, doctor. Thank you so much.
Everything from that little bone graft, thinking outside the box, that last little case, just lift her lip up,
Yeah.
so clever.
Yeah,
Is that
yeah.
whole thing about the gummy smile? That
Yeah.
really is plastic surgery. I understand why you call it that.
Yeah, thank you.
Is,
Thank you so much.
Yeah, and then of course a quick, easy, step-by-step technique to be able to
Yes.
do the aesthetic gingival contouring and
Mhm.
and the associated bone